Thank you, Target, for inviting me to present today. And I'm delighted to be here to present to a group of women and their loved ones on this topic. It's not often we get an opportunity to speak directly to women, so it's a real opportunity for us to interact with you. So I'm really looking forward to this interaction. So I'm going to speak on accurate and timely diagnosis of ovarian cancer, following neatly on from Adam's fantastic talk. So a bit of a blurb in terms of the introduction into ovarian cancer. Nearly 200,000 women will be diagnosed with this, and for the majority of ovarian cancer, unfortunately, will be diagnosed at advanced stages, i.e. stage 3 and stage 4 of cancer. This data is from Cancer Research UK, and basically the net news is positive in that 1 in 2 women, or just under 1 in 2 women, will survive 5 years after, will survive at least 5 years after diagnosis of ovarian cancer. And that's really positive. But the startling news is that survival is very highly stage dependent, and certainly this is the driver between an accurate and timely diagnosis of ovarian cancer, in that if we're able to identify ovarian cancer earlier, either through screening or through other identification of populations at risk, it is possible for survival to be much higher. And there's data certainly from national data sets to suggest that in the UK we could improve on our outcomes in ovarian cancer. Partly it's because of the diagnostic pathways by which women are diagnosed, and only 1 in 3 women will be diagnosed through rapid access referral pathways from their general practitioner. 1 in 3 women will be diagnosed as an emergency, and 1 in 3 will come through other referral pathways. And this is really the subject of what we're trying to achieve in terms of trying to improve accurate and timely diagnosis or earlier diagnosis. So we know that ovarian cancer is associated with symptoms, but these symptoms are quite challenging in that they're also very, very common. Peter Sasseni in London estimates that 1 in 2 women will present to their GP between the ages of 40 to 70 with these symptoms once a year. And these symptoms are abdominal distension, so tummy bloating, feeling full quickly, needing to wee more often, and changes in bowel habit, sometimes a bit of tiredness. Postmenopausal bleeding is one of the symptoms. And GPs have been advised to carry out tests if these are new onset symptoms, so it's abnormal for you, or if they're particularly persistent, i.e. this isn't a one-off, that these symptoms tend to cluster more frequently over the course of a few weeks. So Target Ovarian have an app that allow you to document these and form a symptom diary that can allow you to trigger a referral to the general practitioner and then so on. But these are challenging symptoms, and I think it's quite important to acknowledge that actually, whilst we know that ovarian cancer is associated with symptoms, we haven't quite got a clear handle on how we then tease these symptoms on to a diagnostic pathway that allows accurate and timely diagnosis. What do we know in terms of the evidence for symptom-triggered testing improving outcomes? Well, we know that in a relatively smallish study, a larger study in the whole of Quebec province is ongoing, that if you test on the basis of these symptoms, you result in women being diagnosed at lesser amounts of cancer, more cancer being completely removed, lesser CA125 levels, but it's not a stage shift. So we aren't able to identify, or certainly in this study, they weren't able to identify women at stage 1 and more women in stage 1 and stage 2 cancer, but they could identify women at a better performance status, so when they were fitter to have treatment, and the surgery itself seemed to work better because there was lesser cancer. So it's worth doing, but we only have preliminary data, and that data needs to be replicated in a larger study which is ongoing. So the research that we're doing is looking at testing to try and see how we can identify, how we can tease out these women who have symptoms from ovarian cancer from the more broader pool of women who have symptoms. So NICE guidance recommends that women who have these symptoms present to their GP, and that then the GP tests these women with CA125. If the CA125 is abnormal, then they have an ultrasound in primary care. If the ultrasound is abnormal, then they're fast-tracked to a referral to secondary care, to hospital. NICE guidance didn't specify what age groups of women needed to be tested, what levels of CA125 were considered abnormal, or what ultrasound features would be considered abnormal. Unfortunately, this is a great start, but there's lots more to be done, because we know that ovaries produce cysts. I mean, that's the raison d'etre for having an ovary, that they produce cysts. And so we need more clarification on these tests in order for us to be able to pick up the women with ovarian cancer earlier, when they have lesser cancer, when they're fitter to undergo treatment, but also make sure that we don't end up with hospitals having lots of women who don't have ovarian cancer, or who have a very small likelihood of having ovarian cancer, because then the women with ovarian cancer don't have the resources that they necessarily need to have best outcomes. So it's a very careful balancing act. CA125 isn't a perfect test. It's raised in all sorts of normal physiological environments, such as having periods, such as having endometriosis, which is when the lining of the tummy spills out into the outside. It's also up in lots of different other conditions. It's also only up 50% of the time with early cancer. So it's quite a challenging blood test to start off with. So ROCKETS, which is the program I lead, basically was funded by the National Institute of Health Research to say, can we find a better test than the risk of malignancy index? And the risk of malignancy index is a combination of CA125 and scanning in women who are both postmenopausal as well as premenopausal, both for GPs to use and for hospitals to use. So it's a huge, big task, basically. Can we introduce better tests? If we scored the ultrasound more carefully, would we be able to identify these women better? And through ROCKETS, we've trained up about 105 sonologists, radiologists across 17 hospitals to use this particular form of scoring. And we are looking to train more people. Would better tests help? If we had tests that added to CA125, blood tests such as HE4, OVA1, symptom indices, would we be able to spot these women better? So this this project brings together the international who's who in ovarian cancer, both in terms of the ability to conduct trials, as well as in people who already have done lots and lots of tests, lots and lots of work in terms of identifying better tests for this condition. So the project itself started in 2014. It starts with looking very carefully at the literature to see whether we can identify which tests exist already. We've been lucky enough that collaborators in UCL, Usha Menon in UCL for UK CTOX, which is the largest screening trial, and the IOTA group in Leuven have allowed us access to their data to see whether we can check their data set to see whether new tests can improve. So there's no point in reinventing the wheel. They've got all of this data already. Can we ask questions of their data and their samples to identify better algorithms that we can test for the future? And then we're also doing a prospective trial which will check to see whether these models that are generated from looking at literature and looking at other people's data, whether they really do work going forward. And finally, of course, we'll have to do a cost effectiveness and pathways as outputs. So for phase 2, we're looking to see the data sets from UK CTOX and the IOTA dataset to see whether we can identify whether better biomarkers or better ultrasound variables are the right thing going forward. In terms of the study we're running to try and validate these new models, we are open to 17 hospitals in the UK, and this is basically women presenting via their GP with these symptoms and raised CA125 or abnormal ultrasound or both. And we allowed for this heterogeneous group of people because we're seeing now that when GPs find women with raised CA125, many of them aren't happy sitting on that result. They're not willing to wait for that abnormal ultrasound before they refer. So in fact, in practice, I see a group of women with raised CA125, I see a group of women with abnormal ultrasound, and I see a group of women with both. So the trial basically includes a fairly broad bunch of women so that we can identify which might be the better tests to pick up the women with ovarian cancer. And for these women, we're asking for them to fill out a fairly detailed symptom questionnaire. We're collecting blood to see whether, to check better commercial biomarkers. We're asking for them to please undergo a ultrasound, which is scored according to these new criteria, to these sort of specialist criteria. And then we look to see what their outcome is in terms of histology, if they undergo surgery, so tissue biopsies, or if they haven't gone through surgery or chemotherapy, for follow-up in 12 months' time. So effectively, we'll be able to look at this data and at the end of 4 years, hopefully be able to identify which tests and which pathways are the right tests for women with symptoms in the community. So these are the sites participating. And in addition to these tests that we already know are out there, we're also looking to see whether we can look at the more novel technologies to try and find better tests. Because it may be that the tests that we have are good, but they're limited, and we can identify better tests. So we're looking at the samples that we're collecting to look at circulating tumor DNA. Many of you will know for pregnancy, for Down syndrome, for instance, it's possible now to do non-invasive testing by looking at plasma, so by looking at blood. So they're able to look at fetal DNA in the mum's circulation. So in that way, we're looking to see whether, by taking blood samples from women presenting in rockets, we might be able to identify whether we will be able to spot the DNA of the cancer circulating in the bloodstream, and using that, whether we're able to find better tests. And it may be that looking at the tumor DNA, looking at tumor circulating cells, we might be able to improve on our current tests for ovarian cancer. And this is an effort that Target are helping us with in terms of securing funding and running further trials for this. So one of the challenges with ovarian cancer diagnosis is that it's actually not one disease. It's lots of different diseases clumped together as ovarian cancer. And that's what I think plagued screening, and that I think is what is making our job to try and find these women with ovarian cancer so difficult. We know that broadly speaking, ovarian cancer clusters into two types. The more common type of cancer, which is the type 2 cancer or high-grade serous ovarian cancer, which we think may be arising from the fallopian tube and probably spreading quicker. And the type 1 cancers, which tend to arise in women with ovarian cysts, tend to be around in the pelvis and tend to be diagnosed when they're still in the pelvis. And this differentiation under the umbrella term ovarian cancer is a huge problem, because actually you need to find a test that picks up all these kinds of cancers with these different histories and these different patterns of spread. But in a way it's good, because it may be that if we are able to identify the tumor DNA, either which is circulating in the blood or that's coming through a cervical smear, for instance, and we're doing that as well, then using these special DNA tests, we may be able to find out not just the cancer early, but what cancer it is. Because these cancers have DNA that's mutated or changed in a particular way. High-grade serous ovarian cancer, for instance, is almost always P53 mutated. P53 is the policeman of the DNA system. It's sort of integral to maintaining the cell as it exists in terms of making sure that the DNA is repeated or replicated properly. So knowing that, it might be possible for us, if we're able to identify the tumor floating around in the system or through cervical smears, it may be possible for us to pick up the earliest possible sort of indication of cancer. So these are all quite exciting times in terms of the science of it. And our job, certainly within Rockets, is, I feel, is to collect as much data as possible so that in a few years' time we'll be able to combine these things to try and find the better tests. So these are the teams that are involved. This is the team for the circulating tumor DNA work with Cambridge and Birmingham. Work with circulating tumor cells, and that's with a company called Angle, who've developed this special cassette, which may be able to pick up cells circulating in the system, and then work that's spinning off from adrenal work. I don't know if you know the adrenal gland. It's sort of situated sort of fairly high up. And for adrenal tumors, it's possible to differentiate between innocent and malignant using urine and urine hormones. And Wiebke Alt in Birmingham has done lots of work, and it's actually entering clinical practice now for adrenal tumors to try and differentiate between innocent and cancer. So in the same way, we're trying to collect urine for patients who are presenting through Rockets to see if maybe urine analysis of steroid hormones can make a difference. So these are all in the pipeline. There's pilot data from one patient with ovarian cancer, so I don't think it's one patient, so we've got to take this with a pinch of salt, but nevertheless interesting stuff where it looks like women, with this one person with urine, with ovarian cancer, looks like she has the same steroid hormone in her urine as women, as patients with cancerous adrenal tumors. So it's interesting data, and we've been funded from CRUK to look at this. So finally, this is the bit that I'm most interested in a way, because obviously we sit here in a background of women with non-specific abdominal symptoms. The reality is some of these women will have ovarian cancer, some of these women will have other equally important conditions like colorectal cancer. Maybe they go on to be diagnosed with other things. And sometimes I think what we need now is to think about a basket of tests for these women with non-specific symptoms, such that we can change the whole pathway where people come in, they see a bunch of specialists together and then go forward. And I know that multidisciplinary clinics are being set up as pilot projects in the NHS ACE program. Rockets is an ACE project. I encourage you to Google NHS ACE. And I really do think we need to think differently in the NHS about how we make a diagnosis of cancer. So finally, in terms of my take-home messages, I think symptom awareness matters. We're at the very beginning of trying to find out pathways that work for women and work within the NHS. And we do need to think of system-wide approaches to try and make a difference to women. So these are the whole team of collaborators that have been part of this work. Thank you.